Good afternoon. I'm one of the cardiologists, but also an intensivist in our hospital, and I had the perfect. You have heard the perfect preparation for my talk, to be honest. So I think when I talk about my point of view, of course, this is like how you can imagine it goes in a patient. You have a certain substrate, then something happens, a certain trigger that pushes the patient into VT, and then basically the patient gets locked into a vicious spiral because the patient is shocked. This increases the adrenergic tone, and we all know that, of course, if you have more catecholamines, this can induce recurrent VT. And on the other side, the patient probably already has heart failure or some substrate. There's some stunning after the VT. There's some local ischemia maybe, and you come into a certain state of acute heart failure, which leads to increased filling pressures, ischemia, and this as well induces recurrent VT. And it's a spiral because the recurrent VT will bring you back up again. And so basically what we want to do in critical care after the patient was kept alive or brought alive was keep him alive until he receives a more definite treatment, because most of the things we do are not an etiological treatment. It's just stabilizing the patient and creating the possibility for example, the EP doctors to ablate the patient, or sometimes for the heart failure doctor to do something really at the core of the problem. So how can we do that? I think if you see the graph, there's basically two culprits that we tackle to break the circle. The first one is the adrenergic tone. That's we all know that. This is like, there's not so much data about deep sedation, but just to illustrate you, this is a recent paper. So what you typically see is that the patient is brought into a very deep coma, typically with for example, propofol. This suppresses the adrenergic tone, and this often eliminates the arrhythmias. But what we also know from ICU, because I mainly do ICU, is that when you keep a patient intubated, you get problems. You get a ventilator-induced lung pneumonia. You can have all types of catheter-related infections. And if you wait long enough, they will weaken, and then you might not be able to wean them from the ventilator. So this deep coma is not harmless. And so I think you should look at it as a step-up strategy. And the first thing we do when we can is beta block the patient, because that also targets the adrenergic tone. And what can I say about that? Well, something I've always done since this paper is tried to get them on propranolol, because we have some data, and this, for example, it's a randomized trial. It's not a retrospective study. It's a small number. It's often small numbers in these kinds of trials. It's like the ProCameo study was also small, but there was a very clear benefit of propranolol in patients with VT storm. And this has been shown over and over again also in certain populations like CPVT, for example. There's also some data. So I think I always try to get them onto propranolol whenever I can. Usually if you do it 4 times a day, it allows you to titrate it pretty rapidly. And then if beta blocking is either not possible or especially when it's not enough, then you can step up and sedate the patient. And then you have all these options. And I think if you look at it, ketamine doesn't really make a lot of sense, because actually the reason you're more stable with ketamine is because you have more adrenergic drive, which compensates for the fact that actually the molecule itself is even slightly negatively inotropic. And then you have midazolam and propofol. But we know if you put somebody on propofol and he's not intubated, then it's like when you start to increase the dose, it can get quite fishy, because the breathing and the airway tend to get compromised. So that is an issue, and then very rapidly you end up with an intubation and actually in the peak of the pyramid. So what can we offer? And something I think is underutilized currently still, that is dexmedetomidine. It's actually a drug that I think in the veterinary medicine they use it very often. We use it as well in the ICU. It's a sedative, and it's an alpha-2 agonist. So it basically inhibits centrally your adrenergic tone. And there have been some small bench studies to look at the effect on arrhythmia and the effect on, for example, the QT, etc., etc. And definitely it has never shown to be pro-arrhythmogenic. And there are some studies that it even, apart from the effect on your adrenergic tone, it might suppress. And we do have data. There's no good randomized study in the context of VT Storm, but in all the trials, and this is mainly cardiac surgery studies that they did to see if dexmedetomidine has some advantage when you use it after or during cardiac surgery. There was a very strong reduction in the arm of patients that received dex, to have less ventricular tachycardia, a little bit less AF as well, but especially VT was clearly suppressed. And so I think this is an option. Why? Because when you suppress only with an alpha-2 agonist, you keep breathing. And that's, if you talk to an anesthesiologist, the reason they tend to use it for the conscious sedation patients, and you can bring a patient quite deep, but they still breathe and they still have airway reflexes. So that is a step in between just beta blocking and putting the patient completely asleep and intubated. That sometimes works very well. The only disadvantage, of course, you get bradycardia with, but that's a physiological effect, and that will sometimes necessitate pacing. And then I think, well, actually we should put something also in these pyramids, and that is that, okay, you can suppress it pharmacologically, but if you look at the physiology of your central nervous system, the sympathetic nerve fibers, they go to this sympathetic chain, which is close to the vertebra. And if you look to the heart, it focuses around, you see, cervically, and it goes through the stellatum, the ganglion stellatum. And this might be a target, and actually it's not that difficult to reach it under ultrasound with a needle. Of course, you have some structures that are quite relevant, such as the carotid artery, but it's not that difficult to reach it. And you can instillate with a local anesthetic, and this blocks actually locally the sympathetic chain, and this can have a very dramatic effect on your sympathetic tone. The patient will have a Horner syndrome if you do it on that side. Usually that confirms actually that you put a block. And we do have quite some data, no good randomized studies, but very consistently in all the studies that they did, you see a dramatic reduction in the number of ventricular events or the amounts of shocks the patient received. And I've been using this for quite some time, and it can be like enough to stop completely the arrhythmia. And actually, we had a patient very recently, and so you can block it, and you can also put a catheter and give a continuous infusion to keep the block alive. And in that patient, he was perfectly stable, and as soon as the balloon was empty and they needed to change it, he immediately started to do arrhythmias again. So it really nicely showed the effect of a stellatum block. And then, of course, if everything else fails, you will need to intubate the patient and then put him deeply into sleep. And I would propose to prefer propofol because of many reasons, but we have a lot of data that if you keep patients for a long time on midazolam, firstly, it's not that powerful to suppress, but secondly, you have much more troubles when you wake them up. They are much more in delirium, and they have much more cognitive effects afterwards. So we prefer propofol. And actually, in our hospital, one of the anesthesiologists in his PhD proved that it's safe, for example, to put somebody, because that was always a question I had. We know that it can induce a Brugada type of ECG, especially if you know the propofol infusion syndrome that also starts with such an ECG. But it seems safe to use it in almost every type of arrhythmia patient. And he proved that actually in his PhD that you can put these patients asleep. Then the other part of the vicious cycle, it is the state of acute heart failure, of course. And it doesn't make a lot of sense, in my opinion, if the whole problem is adrenergic tone, and this, which means actually on a muscle, in the muscle cells, cyclic AMP and GMP that are elevated, to give inotropes. Because, okay, dobutamine, everybody knows it will give arrhythmia, but basically all the other inotropes, they all work by increasing cyclic AMP or GMP, and they all give arrhythmias. Levosimendan less, but even that can give you arrhythmias. So you end up with the need for some way to support the patient, and that can be mechanical circulatory support. And of course, that's kind of my interest. So what I will show you is just the options you have. And I think it's very important to choose the strategy based on the problem and the type of the patient, and not just put everybody on one device. And what do we have? Well, we have three goals, in my opinion. You have the goal to provide adequate oxygen delivery, just to keep the patient alive and to keep the organs alive. Then you want to reduce myocardial wall tension, because everybody that cares for heart failure patients knows this. When the wall tension increases, this drives arrhythmia as well. So sometimes you can even stop the arrhythmias by reducing the wall stress. And then you might want to keep them stable when they are doing that much of arrhythmia continuously. You want to do something to keep the blood flow going even when they're in VT. That can be a goal. That shouldn't always be the goal. And so what are the main differences in these devices? Well, if you look at it at the standpoint of oxygen delivery, well, you have the intra-aortic balloon pump, which is basically blows up during diastole to increase coronary perfusion. And then, because it rapidly deploys, you create a kind of a suction effect and you decrease afterload. And this can increase cardiac output a little bit, but not a lot. And that's one of the reasons it probably fails in many patients with cardiogenic shock, because the increase is like 0.5 liter a minute. Then you have Impella. Impella is actually a catheter, and mounted on the catheter you have a small axillary flow pump, and it sucks the blood out of the ventricle to the ascending aorta. And depending on the type of Impella you use, you will have flows between 2.5 up to almost 6 liters. But you can imagine the more flow you want, the bigger the pump will be that you insert. And in practice, basically, you have either a 4-liter pump, the CP, or you have a 5.5-liter pump, but that needs to be inserted surgically because it's too big to just put it in. And then the tandem heart device, we don't have it in Belgium, so I put it out of the map. And then you have VA ECMO. And VA ECMO is actually not really cardiac support, it's organ support, because you bypass the heart. What you do is you pull venous blood out of the patient from the inferior vena cava, and then you push it through an oxygenator and you return it on the arterial side. Typically, when it's not after cardiac surgery, it's inserted from the femoral artery in the femoral vein. There are some variations possible. And that can, of course, provide you also very high flows, up to even 7 liters, although you need to have very, very big cannulas if you want to draw 7 liters out of the patient. And then if you look at the AIBP, as I said, it provides you not a lot of support. So if the cardiac output is very low, it doesn't really make sense to put in a balloon pump because it will not increase enough. But there are some subsets of patients that respond very well. And actually, a friend of mine in Rotterdam did a randomized study, and he showed that the effect of the balloon pump was bigger than the effect of starting enoximone, which is an inotrope. And of course, the endpoint here is venous oxygen saturation, but it does drive home that it's even a little bit better. But these were all advanced heart failure patients with big dilated ventricles. And that is typically the phenotype that responds quite well. And as you can see here, these are the parameters to look at. So what are the typical things? You need to have a decent right ventricle because a balloon pump doesn't really support the right ventricle. You need the typical cold and wet patient, so a very vasoconstricted patient with a very weak ventricle tends to respond. Why? Because you decrease afterload. And then it helps to decrease filling pressure, but it's not that powerful. So if you have like a wedge of 40, it will be difficult to bring that down. And the main problem in arrhythmia is, of course, it's cycled on the ECG, which means if you have a very bad looking ECG with a lot of ventricular ectopy and AF, it doesn't work. So in those patients, you shouldn't put a balloon pump. Then the second goal is to reduce myocardial wall tension, basically filling pressures. Well, the balloon pump does do that because you reduce afterload, but the effect size is like immediately if you put it on, it's a few millimeters. If you do it for 24 hours, for example, in the Rotterdam subset of patients, it was like 10 millimeters of reduction, but that's because then they combine it with diuretics, etc., etc. The Impella, that can really rapidly reduce filling pressures, of course, because you suck the blood out of the ventricle. And if you take a very big pump, like the 5 liters, you can immediately normalize the filling pressures. The biggest the most important thing to realize is that with veno-arterial ECMO, you will potentially increase the wall stress on the ventricle, and you might increase oxygen consumption. And that might be a problem in a heart failure patient with continuous arrhythmia, because that can continue the vicious cycle of VT. And that's illustrated here in this graph. You see a PV loop, basically what happens during one cardiac cycle. If you follow the dotted line, you see the filling of the heart, basically. You have the volume on the x-axis, the pressure on the y-axis. And so you fill the ventricle until here, which is end diastole, so the end diastolic pressure. And then you have the isovolumetric contraction, ejection, and relaxation. And what we know is that the area in the loop is basically stroke work. It's the amount of energy you consume during one cardiac cycle. And if you put an impella in the patient, the loop will shift downwards and the shape will also change because you continuously suck. You don't have an isovolumetric phase. But in essence, it becomes smaller. So the ventricle will waste less energy because it is less filled. And here, the red is the passive energy expenditure that will also go down. If you look what happens when you put somebody on ECMO, it's exactly the opposite. You will get a shift to the right, even though the loop becomes smaller because you take out some of the volume, but also because you increase afterload, the total of energy expenditure, it will increase. So that's very important to realize when using VA ECMO. And then, of course, you can combine two devices. This is on the left side, a patient in our unit. So you can use the impella to cope with the afterload of the ECMO and the increase of the filling pressures and unload the LV. And there's increasing data, and it's kind of a hot topic in the MCS, that the earlier you unload the heart, the more chance of recovery and the better potentially the outcome. But you should know, is a picture of a patient I did during the night. And you see it's a lot of cannulas. You can imagine it's a lot of bleeding risk in such a patient. And actually what happened, so you have here the VA ECMO. Usually when I'm doing it in resuscitation, I do it on one in the same leg. You connect actually the oxygenated blood to a cannula that goes down in the leg to protect the leg for ischemia. But then you put in an impella, and in impella you don't have that. So if the patient is very vasoconstricted, you get ischemia of the impella leg, and then you need to cross over and put a sheet downwards, and you can cope with it, but you can imagine this gives a lot of complications. So the more and the bigger the devices you use, the more harm you do to the patient as well. And then if you want to maintain stability throughout the VT, you need to realize that it's a biventricular problem, VT. And of course, if you use a device that only supports the left side of the heart, you might have problems. The balloon pump, it doesn't give you enough flow and it doesn't support the RV, so forget it. Actually, impella, it can provide a lot of support, but the LV needs to receive the volume that you're pulling out, which means that if you're in a very rapid, like if you're in VF and the right ventricle is not contracting at all, you have a Fontaine circulation. And if you grow up with it, it works. But if you acutely make a Fontaine circulation, it doesn't always work that well. While VA ECMO, of course, it will provide stability. And this is typically what happens. You have the arterial waveform and in green the LV. Well, when you go into VT, the LV does not generate enough pressure. The arterial pressure go down and then you die. If you have, for example, an impella, it was the 5 liter in that case, in place, well, what will happen is the LV will still do the same thing, but you have a continuous flow through the pump. And even though you will have no pulsations, you will maintain with a stable blood pressure. And that, of course, is also something that is sometimes used to be able to ablate a patient to maintain stability during induction. But what people sometimes forget is this. It's like, I think it was 6 minutes in between the two images, and you don't need to be an advanced imager to see that the volemia of the ventricle becomes a problem. Well, this is a patient with a bad right ventricle. And so if you increase the pump speed, you will have more venous return, but the right ventricle will not cope and will blow up, and you will completely suck empty the left ventricle. And they call these suction events. But in essence, you need to take that into account if the goal is to keep the patient stable throughout the VT. So you will need to take into account what type of arrhythmia. The faster it is and the more it's going to VF, the more the less the RV will contract and the more difficult it will be. And especially look at the underlying disease and whether the RV is sick or not. Voila. And then I will skip this. This is about the use of support throughout ablation. There's some data, but no good randomized studies. And so this is the end. And so if you go back, what can we do? Well, we try to reduce adrenergic tone. We beta block the patient. I think we can think about DEX before we go to deep coma. We should really think about stellatum block. I think it's still underutilized. And then we should think early about mechanical support. The IABP can be useful, especially to evade inotropes. It's definitely better than giving inotropes in many of these patients. But and then remember that if you want to keep the patient stable throughout VT, that you will need to look at the individual hemodynamics to decide which device can do that. And then just to close, I wanted to say that actually, as was already said, it's really a multidisciplinary thing. And we've been working on the shock team, and now we're hoping to expand the whole thing. And so we have a dedicated number that you can call from outside the hospital, and you immediately get the lead of the shock team on the phone and discuss a patient if you want. And then thanks to, because I thought Professor Hublou was going to also talk about his new project, but there's a very nice ambulance project to retrieve difficult patients. And so the pictures you see is a patient actually, it's a trajectory of a patient that we went to another hospital, we put him on ECMO, and then we brought him back to our hospital and arrived in the cath lab. And thanks to this new ambulance project, we will be able to take home the most difficult patients if needed. And you can always call us for that. Thank you.